早安。
早安。我们档案要怎么样弄出来？
那意思给我来理一下。你是有 email 给我还是用？
没有，我是记得自己的信箱。
好，
开我的信箱，线内的。
好。喂，你好，嗨，要不要？Okay, yeah, I will.
Yeah.
I will wait a second. Okay, thank you. 意思你等于从这边登一下。好。我下礼拜一起来，然后看你们那节目来帮你看。哦，那你们可以跟我一起做。哦，好啊，好啊，好啊，谢谢，谢谢。
你这是什么？
不能喝了，想要不要？
不能喝，然后要不然你
今天还要体检，我现在低渣饮食，那些都不能吃。
哦。下载哦。
好，可以现在在那个桌面这部记得是我的，这次我先帮我签个名片。
好，好，谢谢。
谢谢你刚才帮我签一下，谢谢。
想知道保CRP 和formulation吗？
然后他的那个地址可能也要写一下，
地址也要写，
因为那个会计他们那边但是留这个，但我们都是不会留地址，但是好，先帮您登出哦，这个 email。email 登出了，那我现在过去试试看分享那个画面。那待会的话， 思是帮我们下载在桌面嘛，对不对？是桌面的，
应该不是桌面，
不是哦。
找到无存的。
那下载的档名是可以再帮我确认一下，它的档名是好，谢谢。
移到桌面。
好。医生，我可以请教一下，因为我们分享画面啊，变成对方看的画面跟我们一样，就会是这样子的方式呈现。那因为是有一个方式是可以，只要因为我按那个投影片的话，有一个方式是没有这个备忘录的。
好啊，没关系，不用备忘录。
不用哈。
等一下备忘录删掉。
哦，我好像不太会调，因为。像备忘录，
把它删掉。备忘录是我要讲的。
真的，但是等一下，我其实我觉得应该是可以，只是投影的方式。
把它删掉，因为我有印出来。
哦，那这样好像你。但是我还是觉得应该不是这个问题。那我试试看，因为应该是设定的问题，因为你看呢，我按播放。
因为我没有写很多。
你看它还是一样，即使你没有备忘录，它还是。
哦，没关系，我。
对，因为对方他看的是我们的分享的画面，所以如果马来西亚等一下看的话，他会跟我们这个画面一样，他就看不到这个。我想对方看这个是不是可以设？
那个显示啊，
我记得好像你们上次设过，在哪里设？顺便看一看。因为我们上一场那个防疫视讯也遇到这个问题，
这样就可以了。
对啊，你按了什么那么厉害？
就是切换那个检视的画面。
可是为什么
其实这里
是备忘感？
因为那个，
对，你在做，
那就是不要有那个备忘录。对。
显示设定，然后
为什么会 echo 成这样？
没有，好像是对方的。是我们吗？不是我们吗？怎么会看？
这样就可以了。哦，那你看。
哦，对，这样可以。
你看我们的 echo， 对啊。
对啊，为什么有人声音？
而且会 delay 很久才出来。
delay 好久。对。
他 delay 到我刚才说。
用 WiFi 还是用
用 WiFi
还是我们开？
好，我 share 我的好了，我觉得
今天的网络够。
加了。
谢谢你们。
我填这里哦，就是那个给我这。
哦，是啊。
对，那我填这里哦。刚刚才发现。
你是就是马来西亚。你是马来西亚？你好，我是香港人。
哦。
所以我
才会被安排过来。
是因为我们看起来都看不出来。
对。
然后我也不太会听你的口音，我也听不出来。因为我自己讲也有口音。所以我听不出。我连我的那个 WiFi 好了，用手机分享，因为一定关不完。
1到5啊。
3月13号。
1到5点了，
哦，到了，
可以，拜托，谢谢。
不好意思，
会有
你待会
2000块，
而且谢谢
录销本来才1000。
其实你可以坐前面啊，等一下录定。
啊，坐哪边？不是我这样子吧？
我等一下会移过去给你。
你说这个移过来？
对，我这个会移过去给你。我会调让大家都可以出镜。怎么办？我们的 echo 好严重。
要吗？其实就只有讲4篇以前。CAR， 一个 CAR， 讲那个 Coordination， 还有一个就是最早期Differentiation， 一个 Quality Differentiation 的高级的。
口水分析
哇，我感觉很艰深，我会睡着。
等下这就不电台了，现在。
我觉得我们今天的网络有点不太稳定。
好一点吗？
声音还是好怪，对不对？
我觉得，你的声音应该从这里录制才对，从这里出来，因为刚刚是从这里出来。
Hello, test 1, 2, 3, test mic. Tu nampak dia orang tak? Mana? Ni. Dia orang pakai background belakang tu. Your place.
Belum, tunggu Prof. Why because dia yang akan moderate.
Oh.
Jadi moderator.
Oh, dia nak cakap saya boleh cakap.
Ya ke?
Bukan.
Tapi dia tak cakap apa-apa.
Dapat Dr. Lee pun boleh kalau tu.
Break for Prof. Wai. Tak perlu.
Tak payah kot kan.
Tak payah kot.
Tak payahlah kita start awal sudah.
Okey lah, boleh.
Oi, nanti
I cakap dengan ni, kita start dulu.
Dia tanya dia dulu.
tanya kita boleh start dulu lah. Macam tu. So the presentation today lah.
Which one bro?
Fellowship one.
Today I need to go present or not?
Just present lah.
Where?
I think okay, I text you the venue. How's everything do? Okay.
Okay.
So kalau saya present, connect.
Hello, good morning. I am fellow colleague in University of Malaysia. How are you? I am Dr. Kai-Ping Chang, professor of hand surgery in Department of Otolaryngology Hand Surgery in Chang Memorial Hospital. Today we are very pleased to have this conference with you guys. I am fellow colleague in University of Malaysia. How are you?
Yeah, there's a lot of echo. What's the reason there's echo?
In Chang Memorial Hospital. We are very pleased to have this conference
issue. We are hearing a lot of echoes. Do you have the same problem?
No, we don't. So it's okay here.
Okay, that's great then. It's good to be with you all as well. Very nice to see you, Dr. Su. I am Professor Vairavan. I'm a neurosurgeon, and I will be moderating on our side here. And we are very happy to be here with all of you all to discuss this morning's topic. Shall we start? This ongoing collaboration we have between UM and Chang, it's something we have been looking forward to for quite a while. And today we have head and neck cancer from our otolaryngology team. And with me today, I've got Professor Muhammad Zulkifli Abu Bakar, who is the Deputy Director of the hospital, as well as a consultant ENT surgeon. And I also have got Dr. Liu Yu Tong, who is also a consultant ENT surgeon in University of Malaya. Both of them are specialized in the field of head and neck cancer. And we would be sharing some of our work with you, especially in head and neck cancer, the facilities we have, the kind of work we are doing, and the future collaborations we want to continue with Chang as well. So I hope the discussion will be very fruitful today. Dr. Su, you want to introduce your team?
Let me introduce Professor Shi. He is the director of this program. I think he has some remarks before we begin this topic, this session.
Thank you, my dear friends. It's my great honor to pave the way to the academic collaboration between the Taiwan Chang and the University of Malaysia. And I believe this webinar meeting will forward our mutual collaboration now and the future. So now I just invite Professor Chang to chair this section.
Today we have Dr. Gu Haofang. He is an excellent hand surgeon in our department. Then we have another physician, Dr. Dai Xiaofu. She originally come from Malaysia, have a medical school in Taiwan. Now that he is another excellent hand surgeon in our department. So I think both of them are going to have some information to share with you. So we start, and they are going to talk about the treatment of oral cavity cancer, which is a major healthcare issue in our department and Taiwan. So we start from Dr. Gu Haofang.
Hi, everyone from Malaysia. Thank you for kind introduction from Professor Chang and Professor Lee. It's my honor to present my work in prognostic factors research for oral cavity cancer. Yeah, I'm Gu Haofang from Chang Memorial Hospital.
Dr. Ku, your presentation, I think, is too large. I'm not sure why we're only seeing part of your slide. Yes, much better.
How about now?
Still big. If you can put the slideshow, I think. Click on the slideshow at the bottom. Yes. Fourth icon.
Okay.
This one. Can we press on
对，
it?
然后不要放映，就让它那个下一张不要放映。
Now the slide is okay.
Okay.
Yeah, as we know,
yeah, you need to press the slideshow icon. It's still not the slideshow.
他叫你放映。你有分享吗？
okay, the slide is
Is it better now?
better now.
Is that okay? No, we're still seeing only part of your slide.
How about now? Is it better?
Dr. We are still seeing only part of your slide, I think, because it's not in the slideshow format. Yes, can you see at the bottom, if you can press the fourth icon, there was a first, second, third, and fourth. You can go down to the bottom.
Is it okay now?
We are still seeing part of the slide. If you go down to your PowerPoint itself, on the bottom right-hand side, there are 4 icons. Or here?
Yes. Yes, we can see the full icon.
Yes. Oh, no, earlier. Whatever you did earlier. That was very good. Yes, okay, can. I think.
哦，好像是他们那边的，是不是？
This is very good. Thank you.
Okay, thank you. Once again, it's my honor to present in this virtual meeting. Yeah, I'm Gu Haofang. As we know, the incidence of oral cavities cancer varies greatly in various parts of the world. In fact, Taiwan has the highest incidence of oral cancer in male in the world. However, because of the political factors, we are not a member of the WHO. So this picture cannot show this fact. Taiwan should be red in this map. And also in this picture, we can see that the incidence of oral cancer in female is also different in different geographic areas. Taiwan should be the yellow color, not green, in this picture. The incidence of oral cavity cancer in male in Taiwan is 25.7 per 100,000 people. The predominant site of oral cavity cancer, similar to India, are tongue and the buccal mucosa, but different from Western countries, which are tongue and the floor of mouth. The risk factors are also different in Taiwan, including the low socioeconomic status and the betel quid chewing without tobacco, smoking alcohol, etc. These two landmark papers from New England Journal of Medicine show that the major risk factors for oral cavity cancer are margin positive and the extranodal extension of lymph node. RTOG group also include more than 2 lymph node metastases in its inclusion criteria, while EORTC include pathology T3, T4, and perineural invasion, and also vascular tumor embolism in each trial. So our Chang guideline, our institute adopt mostly from RTOG risk factors, but we also have our own risk factor. These are including the pathology T4, pathology N1, and also close margin, poorly differentiation, perineural invasion, vascular invasion, lymph invasion, and tumor depth over 10 millimeter. And if the patient has more than 3 risk factors, we will send the patient to receive the adjuvant concurrent chemoradiation therapy. And if the patient have 2 minor risk factors, we will send the patient to receive adjuvant radiation therapy. Here is one example of this risk factor identification. This paper, all the patients, including 150 patients, all received the curative surgery by our Professor K.P. Chang from 2003 to 2007. And we use the pathology factors in 3 different histologic groups, including the well-differentiated and the moderate and the poorly differentiated. In this table, we can find that the poorly differentiated squamous cell carcinoma is highly correlated with the lymph node metastasis, and also correlated with the extra capsular spread of lymph node and the perineural invasion. with a significant p-value. And in this table, we can find that the poorly differentiated squamous cell carcinoma has a higher risk of neck recurrence and also a higher risk of developing distant metastasis. So in the univariate analysis and the multivariate analysis, we can find that compared to well-differentiated, it is still a poor prognostic factor in this study. So in this fashion, we can find many traditional prognostic factors, including the patient's individual characteristic, including age and sex and the personal lifestyle habits and the comorbidity. And also we can find many risk factors related to tumor characteristic, including the margin status, extranodal extension, tumor size, lymph node status, perineal invasion, and the depth of invasion. Besides, we further study our risk factor to the nutrition status and the inflammation-related risk factor. Because we know that several hematological indicators of both nutrition status and the inflammation can be used to predict the prognosis. These include the platelet lymphocyte ratio and the pretreatment serum albumin level, neutrophil to lymphocyte ratio, CRP to albumin ratio, etc. This indicates that the systemic inflammatory response and the nutrition status are involved in cancer tumor genesis and the progression. This is just published in 2020. This paper, 326 patients received the curative surgery by me from 2008 to 2017. The left side picture shows that the pretreatment CRP to albumin is a scatter plot. And the right side, we can see we compare the many inflammatory-based prognostic score. We can find that CAR has the largest area under curve. It means it's a good prognostic factor compared to CRP, NLR, PLR, and the modified GPS. So if we use the CAR as a 0.195 as a cutoff value, we can find that the CAR less than 0.195 has the better overall survival and also the better disease-free survival. And we also use the CAR combined with patient individual characteristics, including sex, age, and also combined with the tumor characteristic, including stage, extranodal extension, cell differentiation, depth of invasion. We can use this Nomogram to better predict the survival of this patient, to predict the 3-year and also 5-year survival. And the next study is also like the previous one. We use the albumin globulin ratio as a prognostic biomarker for oral cavity cancer patients. This study including 306 patients. As you can see, the AGR compared to NLR and the PLR, the area under curve is the largest in AGR. So it means it's a good, it's a better prognostic factors that we can use in oral squamous cell carcinoma. If the patient AGR is more than 1.55, they will do much better than than patient less than 1.55 in overall survival and also the disease-free survival. And again, combined with other clinical pathology factor, we can do this Nomogram, and we can easily more accurate predict the patient outcome 3 year and 5 year. And also we use the novel biomarker and the genetic information to predict our patient's outcome. This paper is from 2000 to 2007. Also 159 patients included in this study. Previously, we used proteomic method to identify, to compare the tumor and the lymph node, different expressed proteomic protein. So we can find that some candidate gene from oral squamous cell carcinoma, and the BST2 is one of them. So we use the IHC stain in the left side, and we can see that the normal epithelium is not stained, and the tumor and the lymph node is highly stained, the BST2. And the right side, the IHC score is also shows significant differences from normal epithelium to tumor and the lymph node. So we can separate the BST low expression group and the BST high expression group. And we can see that the low expression group has the good overall survival and also the good disease-specific survival and the disease-free survival. In the multivariable analysis, we can also see that the BST2 has the hazard ratio of 1.8 and 2.1 in the multivariable analysis. So we have some take-home message. We identified many prognostic biomarkers for patients with oral squamous cell carcinoma. Quantitative factor combined with the clinical pathological factors into the current TNM staging system might strengthen the accuracy of prognostic prediction for oral SCC patients. However, it is still challenging for us to optimize treatment based on prognostic factors, especially patients with multiple risk factors. Thank you.
Thank you, Dr. Fang, for your very detailed and awesome talk. Because I think time is limited, so
Without a question,
Q&A. If there is any comment or the question from our colleague from UM.
Dr. Koo, that was a very interesting talk. You have obviously done a lot of work over the last 15 years. And I can see that some of those papers you presented, there's a large number of patients and you have done some very innovative work. So that was quite interesting. Thank you. We don't have any questions at the moment. I think maybe we can continue with the next session then.
Okay, thank you.
Yes. Then I will now introduce my colleague, Professor Muhammad Zulkifli Abu Bakar, who is the Deputy Director of the hospital, as well as the previous head of ENT department. He's also a consultant ENT surgeon specializing in head and neck surgery. He will be sharing with us about the advancement in treatment of head and neck oncology in University Malaya.
Thank you, Prof. Vairavan, for the introduction. Okay. All right. So, where how to go to the slides? Come. Okay, just bear with us for a little while. I'm going to share you some experience in our center regarding head and neck oncology, especially new advancements in this field. So, shall we have slides on? Session. So you all can see my slides?
Yes.
You all can see it. I think you know. I mean, they all can see, but on our side can see their side. Can see it not? Sorry? Enough.
Can you see the slides?
No, we cannot see the slide.
Can you allow sharing, please? Because I think the host has disabled participant screen sharing.
Please try again.
So you all can see now?
Yes, we can see.
see.
Very clear.
All right, thank you. Okay, Zol here from ENT. So I've been working with with Prof. Vairavan quite some times. So we have a very good collaboration in terms of skull base and few other endoscopic surgery with them. He's under neurology, neurosurgical. So my colleague here, Dr. Liu. So we have very good team in UMMC. So UMMC is a tertiary center. We have a referral from everywhere. We accept from, of course, nationwide as our country, and then Asian country at the same time, Vietnam, Myanmar, Thailand, and Singapore, and Indonesia. We have a lot of complex cases handling with, multiple involvement of the areas, especially carotid, sometimes trachea and esophagus, especially in thyroid cases. And we also offer fellowship placement or clinical attachment in PPM or UMMC, University Malaya Medical Center. So far, we received fellow from Europe, Middle East, Africa, and regional. And of course, we will accept local placement at the same time. So we done it quite some time. So far, the response very good. And within this year itself, we received almost 10, never fail 10 applications per year. So we only accommodate 2 or 3 per year because we can't go more beyond that. And cases so far, from one of the logbooks I've seen, within 3 months, we have easily 100 cases. And then plus minus with complex cases around 30 per 2-3 months like that. Okay, we have very good amount of cases in here. Okay, back to the business. Here in oncology, we have upper digestive tract, facial-cervical region. So for aerodigestive tract, most common here in Malaysia is NPC, and next we have oral cancer, and others. Sometimes we have CA larynx, CA tonsils, and sinonasal tumor and sinonasal cancer. This, statistics we can extract from our registry, and obviously we not preserve from NPC, one of the most common cause of death in Malaysia. And for facial cervical, we have metastatic lymph nodes, thyroid cancer. Others, we have parotid cancer, skin cancer, and temporal bone cancer. Okay, this is the most common presentation for nasopharyngeal CA, likely to be 30% of them. So those having a characteristic like, some ethnicity like Chinese, Bidayo in Sarawak, sorry, so come to us with lymph nodes without other symptoms. We have to look at the nasopharynx. And another thing, sixth nerve palsy on the left side, as shown in this photo, and unilateral hearing loss with a serous or effusion in the middle ear. And this is a nasopharyngeal region. Fossa rasumula is a common place we found at this cancer, this tumor. And this is the one, showed with the lesion over the left nasopharyngeal, left fossa rasumula. And other tumors, we handle temporal bone cancer, like this case, and others like larynx tumor. This is a CA laryngeal CA. Okay, so next, what we're going to do on these patients, we have to go through, sit down, and with other disciplines like oncology, plastic, and oral maxillofacial to discuss what's our strategy on patients once they come to us. We need to whether preserve the function, or we still preserve the aesthetic of the patient, or as if you can't do anything, at least we do as much as possible to help the patient in terms of palliative. So if we look at the survival rate, 5-year survival rate on this chart, for stage 1 and stage 2, we can see we can more or less reserve the function of the patient physiologically or anatomically. Whereas for stage 3 and above, we can see cosmetically we can sort of consider on stage 3 and 4. However, towards advanced cases, most of the time we can't really preserve the function and cosmetic. Other than that, we can go towards palliative. So if you look at the survival rate, if you go from stage 1 and 2, survival rate is still higher side. Whereas when it comes into regional or stage 3, the survival rate is getting lesser and lesser up to stage 4. So therefore, stage 1, to catch them early is very, very important. So early detection or awareness, surveillance must be done early for them. And for patients' dilemma, patients have to think of the function as well as the quality of life. But most importantly, most importantly is survival rate. So we have to discuss with them how much, if we do something or we offer something to them, we have to think of survival rate at the same time. Yes, some surgeons think we remove everything, but for surgeon point of view, it's successful. But for the patient, probably quality of life will be low, everything will be depressed because the disfigurement, everything. And then we should think of the effect or outcome towards the patient at the same time, not purely for the surgeon point of view. So another things that I mentioned for advancement is the either surgical point of view or non-surgical point of view. For surgical point of view, any advancement should think towards a less destructive or minimally invasive. So here we have endoscopic approach, we have endoscopic suit or endoscopic instruments such as IGS, image guidance surgery, or micro divider to reduce down mortality or to reduce down the complication, even to reduce down ward stay for the patient. And of course, sooner or later, we're going to have robotic in our place. But in this regional area, this area, we have few centers already readily available for robotic surgery. And non-surgical, we should think toward reducing side effects to the patient. Probably we more towards a targeted therapy or radiotherapy, MRT, intensity modulated radiotherapy to reduce down the side effect along the treatment. And prognostic implication, we should go for for oral cavity CA. Here we practice to have a very good surgical margin in which we have only chance. So once we decide for surgery, we have only chance for that patient to either cure or to make things worse. If we don't remove properly, then the recurrence rate will be disastrous to the patient. So we have to decide, and then the only chance to remove whatever, the tumor or extension of the disease into the patient. So at least 2 centimeter visible lesion for oral cavity cancer, whereas for others we go accordingly. And then for neck dissection, we have to decide proper neck dissection on the patient. If neck not, we normally for CA cancer, oral cavity CA, we do selective neck dissection, and neck plus, neck positive, we do functional modified or radical neck dissection accordingly. And of course, right after surgery, we should think either to give a radio or plus minus chemotherapy, and some other cases we should think neoadjuvant chemotherapy or neoadjuvant treatment in order to reduce down complication and reduce down the risk of recurrence. And this is our regular neck dissection. We open up the area, expose up to the mandible, jaw, and the sternum notch. And this is the en bloc remover, as you can see. This is IJV, carotid at the back there. And this, well exposed up to the, from lower down here, up to the skull base. And this is the endoscopic surgery, endoscopy approach for skull-base surgery. So this picture is taken, I think it's quite some time ago. This all my colleagues now flying up higher. So this is Prof. Tang in Sabah, and then Prof. Prepa and few others from Sabah as well. And why endoscopic surgery now a most popular approach for skull-base surgery? Because the evolution of audiovisual and imaging recording system. As you can see now, the imaging system, it can go up to 8K. That means the resolution is very, very good. So we can confident enough to look at to the matter, or look at to the lesion, clearly. And sometimes we need help from IGS. IGS is image guidance, meaning that if you have to have a protocol before you send for the CT scan with thinnest cut of the CT scan, and then from the surgery itself, you can see where exactly you are while doing the surgery. As you can see here, these are one of the captured screenshot from machine. Once we put the what we call it the instrument at this place, and we know where the instrument is. So the tip of the instrument, it shows from here, the grid line here, okay? And another tools that very helpful in doing this kind of surgery is micro divider. As you can see at the left side here, this micro divider is shape up any tumor next to or very difficult angle by looking at the endoscopically, and we remove as much as possible by using this micro divider. Okay, I want to show you some operation we've done before. This is for example of the huge tumor over the right nostril, occupying all the nostril nasal cavity. And we're using a micro divider in this case. Just imagine how much the bleeding it can happen to this patient. And those days, probably we do facial cutting, and then we cut everything. We do Weber-Ferguson and lateral rhinotomy and remove all these tumor by cutting out the face. So nowadays, with advancement of the technology, so we can do endoscopically through the nostril. And intraoperatively, this tumor sucking out, and we debride it. We debride the tumor, shape it using the micro debrider, as you can see from here. See, and then make it faster. So okay, so once we a bit far away from the tumor, the tumor, by using debrider, we call it dancing tumor. That means the tumor is still far away. I mean the area will be far away still from the pedicle. So once we're quite near to the pedicle, then tumor no more dancing. So that I can show it here. We shape up the tumor base. So as you can see just now, huge tumor, now empty, now clear from the surgery. So this is a final look after surgery. As you can see, everything clear. This is normal nasopharynx. So this is nasal cavity, lateral wall of the right nostril. Okay. And next, I'm going to show you endoscopic nasopharyngectomy. So just imagine, okay, for primary nasopharyngeal CA, very sensitive to radiotherapy or plus minus chemotherapy. For those having recurrence, those days, if you have this kind of tumor, we will do huge opening like medullary swing, or what we call it, nasopharyngectomy, open nasopharyngectomy with open face. Nowadays, with the advancement of the technology, we can do endoscopically. So in this case, as you see, recurrent tumor over right of fossa racemolar. So we did a biopsy. Biopsy came back as a positive recurrent. Then once we remove the tumor endoscopically, everything removed up and cleared. As you can see, position of the carotid on the left side in here. So with endoscopic, patient don't need to have a face cut, everything through the nostril. We published this nasopharyngectomy and our experience in European archive before. This is our experience for recurrence T3 and T4 nasopharyngeal carcinoma, which is a very good outcome. Patient less, stay, and then the recovery period is very good. And next, transoral robotic surgery. So like I mentioned to you, it's more precision surgery. As you can see here, they can do, we can do actually a lot of things, especially difficult tongue-based oral pharyngeal as well as laryngeal surgery through robotic. And then we have console, the one we control the robot to remove the tumor transorally. So this myself training, I had training in New York using Da Vinci X1 the latest machine. And then this is another in New York. This is Singapore. I did a training for another robotic by using three-dimensional image. So this Metro robot, we can remove tongue base as well as the anterior part of the larynx by using this machine. So as conclusion, new discoveries in medical field are dynamic. Most importantly, patient safety outcome and outcome of the surgery must get prioritized. Of course, any decision we have to sit down with other colleagues like oncologists, plastic, as well as oromaxillofacial, if needed, with neurosurgeon at the same time for some complex skull-based cases. And we open to our collaboration with we open to collaboration with our colleagues in any regional or worldwide to advocate or to improve the disease management. Probably we can share technology at the same time. I suppose with this presentation and this meeting, we can sort of exchange. This is mean that from Taiwan, they can send us your fellow or students to have attachment to our site, as well as our site can send to you all to have attachment or exposure in terms of experience sharing or whatever, things like even research or surgical exposure. Thank you very much from me. Thank you.
Thank you, Professor. That was quite enlightening. I think you shared with us all the advances in surgical methodology in optimizing our patient outcome. Is there any questions? If there is none, we move on with my second colleague, Dr. Liu, to present his part. Right, Liu. I think Liu will be moving the discussion a little bit into the research realm and talk a little bit more about the research work we are doing here, especially for head and neck cancer.
Hello, good morning. Can you see my slides? I think you should see my slide. And
yes.
very good morning, and we are very happy and very impressed with the research background, research experience from our counterpart. And I'm also glad to hear there's a Malaysian sitting on the other side. Okay, so very good morning and 大家好. Okay, I have I'm not going to bore everyone with a lot of presentation or explanation of all the data, and frankly speaking, I think our side is quite lacking of all this biomolecular research in our university and our hospitals. So we have think of this topic for a potential research collaboration with our counterpart, so that we hope to build a very strong database for to contribute to the treatment of the head and neck cancers. So this is a very general ideas on glycoproteomics in head and neck cancers. And okay, the aims and objectives from the talk. will be to hope to establish a long-term relationship between hospitals, university, or countries, so that we will have, in the long run, have a strong background database on glycoproteomic study in head and neck cancer. And frankly speaking, I think we are all aware that the studies and research on glycoproteomic study in head and neck cancer is definitely lacking. And especially in to date, for the 5-year survival rate for overall head and neck cancer is not good despite the advanced treatment regime available nowadays all over the world. So this is extremely important that we continue the research to look for any potential biomarker which can lead to early detection of head and neck cancers. I'm very sure it definitely will affect and improve the 5-year survival rate for all the sufferers. And second objective of the talk is so that we can explore the ideas on how to proceed with the glycoproteomic studies in both universities. And we wish to kickstart a very solid research protocol between us. So a very basic introduction. I'm very sure our counterparts from the other side are well versed on the glycoproteomic research, because I've read through a few literatures, mostly are from Taiwan. So again, a short introduction on this. A glycoprotein, basically a protein molecule that has a saccharide chains attached to it. And glycoproteomic research is basically a study of protein glycosylation, which is involved in several physiological function and biological process. And we are very glad that progress has been made in these glycoproteomic researches, because it raises hope for identification for early detection marker. And again, the few important roles that glycoprotein play in terms of regulation of the cellular function includes differentiation and proliferation, and cellular interaction with the surrounding environment. And of course, any altered function of the glycoproteins will lead to invasion, progression, or metastasis of the tumor cells. And post-translational modification during a protein biosynthesis play an important role in cellular function. There are plethora of processes, and one of it, the most common, we call the glycosylation, constitute 50 and up to 80% of the modification in eukaryotic cells. And because of this, any alteration in glycosylation frequently leads to cell transformation and malignancy. And here I re-emphasize that the process of altered glycosylation of the glycoproteins frequently lead to the tumorigenesis. So there are lists of FDA-approved glycoprotein cancer biomarkers. They are mostly being widely used in the diagnosis and characterization of cancers out of the head and neck region. For example, the breast, lung, GI, stomach, and the prostate. As for example, the prostate cancers, the prostate-specific antigen, it has been used as a screening marker and also as a marker for monitoring of the treatment response. So this, again, why is it so important? The identification of this event will facilitate early cancer detection and surely enhance the ability to monitor the neoplastic process. And there have been several head and neck cancer associated biomarkers reported, but there are very few useful markers have been applied until now for early diagnosis. Therefore, I think the investigation of this cancer-specific biomarker is urgently needed. So, a strong database on this glycoproteomic profiling will enable us or enable everyone for possible invention of the screening biomarkers, and also especially for the recurrent diseases, because they are the one who had a poor survival rate. And lastly, I would say this background database for this glycoproteomic profiling can be used or being studied for possible new targeted anti-cancer drugs. Yeah, as I mentioned just now, there are few studies on oral SCC, oral SCC, the glycoproteomic novel markers. There are few markers and there are few researchers, and mostly are from your country, Taiwan. And NPC itself, to date, available biomarkers for the early detection of NPC are mostly EBV-associated proteins. But the sensitivity and specificity are not that high. And still, until now, the diagnosis of NPC mainly depends on endoscopic examination and the biopsy. And the previous studies on NPC biomarkers were mostly proteomic studies. Again, I mentioned the glycoprotein, altered glycosylation in glycoproteins are the way to go forward nowadays for head and neck cancers. So the few conclusions from the previous literature I went through, the only few biomarkers were found related, but mainly related to oral SCC. For NPC, there are inadequate glycoprotein studies, and certain biomarkers were related to tumorigenesis, the tumor progression, and even the prognosis. However, the level of evidence and inadequacy of the global data lead to failure to complete the research bench to the bedside, to the use of the bedside program for patients. So I think lastly, what we hope for, hopefully a conclusion and fruitful talks from this discussion will be a potential collaboration between the universities and hospitals, because the collaboration will definitely lead to recruitment of more subjects and with various ethnicity. So a multi-center studies on this field is definitely beneficial for both parties. And the previous studies on this will be mostly on the blood samples. And I personally think that exploration of various samples will include the saliva, nasal mucus, and tissue is definitely possible. So we also could study on new cases and recurrence cases. And we hope to have a very long-term relationship with you all so that the future analysis for survival rate and prognosis is possible. So thank you.
Thank you, Dr. Liu. I think you can stop sharing. Okay. So I think my side, our two speakers, Prof. Zul was describing our clinical services as well as potential clinical collaborations we would like to see happening with Taiwan, while Dr. Liu was talking more about research. And we think these are the two things Taiwan is doing quite well. Your hospital specifically, Chang Gung, is doing a lot of work. And we would like to further these collaborations. And that's one of the reasons Prof. Zul and Liu presented their work. Is there any questions from any of the participants about our presenters? Chat. Look at the chat. Oh. I think there are some chat comments.
Professor. Thank you, Professor Tegu. And Chang'an Hospital and the University of Taiwan focus on NPC, so that we have do such a related associated research for several decades. So it's very glad that we have seen Dr. Liu's interest in this area, and we have a very good collection about the patient blood samples, and especially on genomic DNA. So if you look at our previous literature, we have done a lot of several study on the genomic signature of nasopharyngeal carcinoma. So we would like to see a lot of collaboration between both sides, and if Dr. Liu is interested in the area, we'll welcome you very much to have a more interaction with regard to research with nasopharyngeal carcinoma. We can start from teleconference, and now that in such a era of COVID-19 infection, even in Taiwan, we communicate with our collaborator with the telecom conference. So it's a very convenient and useful for ongoing study. So and thanks again to share your interest with us and progress with us.
Thank you very much for the speakers from both sides. I believe we all inspire from each other. And if there are no more questions, we are looking for the next meeting. And thank you very much.
Thank you very much. I think we enjoyed this very much. So hopefully we continue to collaborate and progress, and we look forward to the next meeting as well. Thank you.